Okay then, good evening. First of all, on behalf of the Sri Lanka College of Psychiatrists, let me express sincere gratitude to Professor Sathya Rao for agreeing to do this presentation for our members, and also Dr. Aruniha Pangama for facilitating this, and the secretaries, Dr. Chamara Vijayasinghe and Sumudu Davita, for all the assistance. So let me briefly introduce Professor Sathya Rao to the audience or to our membership. Professor Rao is the Associate Professor and is the Executive Clinical Director of Spectrum Personality Disorder Service in Victoria, Australia. He is the Vice President of the Australian Borderline Personality Disorder Foundation and the Adjunct Professor and the Associate Clinical Professor at the Monash University in Australia. He has also served as the Deputy Chief Psychiatrist of Victoria, and he is quite an expert on borderline personality disorder. So he's a member of the Borderline Personality Disorder Guidelines Development Committee of the National Health and Medical Research Council of Australia, NHMRC. He has been an invited speaker and has presented academic papers at national and international conferences, been actively involved in clinical research and has published research papers and contributed chapters to books and co-authored books on borderline personality disorder. And Professor Rao, I have a book that you have authored. Hope you can see that.
Thank you.
It's Borderline Personality Disorder Towards Effective Treatment, I think, which you brought when you came last time to Sri Lanka and did a presentation on borderline personality disorder. And it has been quite useful to all of us and our trainees. And he's also a psychotherapist who has had extensive training in dialectical behavior therapy and MBT, mentalization-based therapy, ACT, acceptance and commitment therapy, and psychodynamic therapies. And he has been the head of psychiatric training for Victoria Royal Australian and New Zealand College of Psychiatrists. He was a director of training, director of advanced training, and a mentor for international medical graduate psychiatrists. And he has been the past director of advanced training in psychotherapies in Victoria. And in 2020, Professor Rao has been awarded the Meritorious Service Award in recognition of outstanding service to Victorian psychiatry. So we are greatly privileged today to listen to you, Professor Rao. And yeah, as you know, we don't have much established services in the government sector in Sri Lanka for borderline personality disorder. Although we are quite vigilant about this disorder now, and we find quite a lot of patients. And due to the lack of clinical psychologists in the country, the clinicians or psychiatrists have to play that role as well in the part of psychotherapy and dialectical behavior therapy with the help of psychotherapists that we have. So I think your presentation today will indeed be really beneficial for all our trainees as well as practicing psychiatrists, because you will be giving us an update of the advances in treatment of borderline personality disorder today. Thank you very much again for doing this presentation. And over to you, Professor Rao.
Thank you, Gian, for that very warm introduction and welcome. And good afternoon to everyone. Gian, how much time do I have?
It's up to you, Professor Rao. Usually we go on for 1 hour, 1.5 hours.
Okay, so I'm happy to take any questions at the end, and if you could kindly facilitate the questions, that'll be good. Okay, so I'm going to do a PowerPoint presentation, and I've got a video to show you at the end. Please let me know if you can't see the PowerPoint or if you can't see the video. I'm just going to start the PowerPoint. I'm hoping that you can see the PowerPoint in full screen?
Yes, Professor Rao, we can see it clearly.
So thank you very much. So thank you, Gihan, and thank you, Aruni and Chamara, and all of you at the Sri Lanka College of Psychiatrists. So I've titled my talk Demystifying Treatment of Personality Disorder, because treatment of personality disorder is almost equivalent to treatment of a borderline personality disorder. In fact, these days we consider severe borderline personality disorder as equivalent to severe personality disorder. It will become more clearer as I go along. In the last 2 to 3 decades, the science of personality disorder has taken a center stage in mental health. And as you're aware, personality disorders are the most stigmatized, most misunderstood, and also most underdiagnosed conditions in psychiatry. And we have a generation of mental health professionals who have not been trained to treat or manage people with personality disorders. This is across the world in all countries, including Australia, including US and UK. At present, evidence-based treatments are available only for borderline personality disorder. So let's start with the definition of personality. The simplest definition of personality is that personality is a person's characteristic style of thinking, feeling, and behaving. Now, what is a personality disorder? According to DSM-5, a personality disorder is an enduring pattern of inner experience and behavior, which is thoughts, feelings, emotions, actions, that deviates markedly from the expectations of the individual's culture. It is pervasive and inflexible, and has an onset in adolescence or early adulthood, and is stable over time and leads to distress or impairment. So that's the full definition of a personality disorder. However, many of the aspects of the definition have been challenged. Now, we know that personality disorders can start even in later life. We have a late onset borderline personality disorder, late onset personality disorders. We have seen patients who are manifested with personality disorder for the first time after 65 years of age. And although the most common presentation is in early adulthood, it can also present at any time in life. The symptomatic presentation, although the vulnerability factors could be traced back to early childhood. When you're looking at personality disorders in general, the community prevalence is anywhere from 4 to 11%. The study in Australia has shown that 6.5% of Australian adults have at least one personality disorder. It's expected this is generally the prevalence rate. 10 to 15% is the prevalence rate across the world. So in psychiatry outpatients, nearly half of them have at least one personality disorder, usually in co-occurrence with other psychiatric disorders, depression being the most commonest. Of course, the prevalence is highest in the criminal justice system. In prison populations, up to 20 to 40% of people have a borderline personality disorder, and very many of the others have other personality disorders as well. So personality disorders generally attract high service usage and high treatment costs. And when you look at the suicide rate for personality disorder is almost as much as the suicide rate for schizophrenia, bipolar disorders, depression, alcohol dependence, 10%. So I did a study of the colonial data in Australia, and we have again demonstrated that 10% of all suicides for all reasons in Australia is for a personality disorder, and almost all of them for borderline personality disorder. Unfortunately, across the globe, personality disorders have attracted limited recognition as a public health issue. Most of you would be familiar with the classification of personality disorders in DSM-5. DSM-5 takes a categorical approach for personality disorder. That means it divides personality disorders into 3 clusters, A, B, C. And in each of the clusters, there are different types: paranoid, schizoid, and schizotypal in nordic-centric cluster, and borderline, narcissistic, histrionic, and antisocial and dramatic cluster. And in the anxious cluster, avoidant, dependent, and obsessive compulsive. However, if you look at the research evidence available to date, 99% of the research that has happened in the field of personality disorders is with respect to borderline personality disorder. And as such, we have evidence-based treatments only for borderline personality disorder. Although there are a couple of attempts that have been made for developing some evidence for antisocial personality disorder and obsessive compulsive personality disorder, there is no good evidence for treatment of any other personality disorder other than borderline personality disorder. Also in public mental health, as well as in private sector, the most commonest diagnosis that is made for a personality disorder is for borderline personality disorder. Now, in recognition of all of this, also there is so much of overlap between personality disorders. In recognition of all of this, the classificatory systems have moved on. In ICD-11, we don't have a categorical approach for personality disorder. That means we don't have any subtypes. You can only make a single diagnosis of personality disorder. And you can talk about the severity, you can talk about the trait domains, but we no longer talk about different types of personality disorders. You can, of course, recognize the borderline pattern as a qualifier, which is in fact a good move because there has been very little evidence for different categories of personality disorders, although it has been described and known for several years. So I'm going to now concentrate the rest of my talk on borderline personality disorder because that's where the evidence base is. Treatment of borderline personality disorder, the treatment principles are absolutely applicable to treatment of all the other categories of personality disorders as well. Now, BPD is the most commonly diagnosed, most severe, and contributes to 95% of all personality disorder related suicides. It is also one of the most stigmatized disorder. John Gunderson, the late John Gunderson, he's the one who coined the name borderline personality disorder. And he says borderline personality disorder is to psychiatry what psychiatry is to medicine when it comes to stigmatization. Very apt. The prevalence of borderline personality disorder is at least 1% across the globe. And in mental health systems, it is 10 to 20%. In emergency department presentations, it is about 10 to 15% of all psychiatric presentations. In the primary sector, it is about 6%. Now, when someone gets a diagnosis of borderline personality disorder, they have a 20-year reduction in lifespan, very similar to schizophrenia. And the 20-year reduction in lifespan is not purely contributed by the suicide. It is contributed by the metabolic disorders, because about a third of them, at least a third of people with borderline personality disorder have significant metabolic disorders. And we all prescribe excessive amount of medications for BPD, although there is no evidence at all to say there is any medicine which is indicated or patented for BPD. And also people with borderline personality disorder do not generally take care of their health, and because of self-criticism and self-loathing often. And so therefore there is a significant reduction in lifespan. Suicide rate for BPD, as I mentioned, it is 10%. And non-suicidal self-injury behaviors, which is such as cutting, burning, taking minor overdoses is up to 85%. When I last visited Sri Lanka, I was told that in Sri Lanka, one of the significant problems is people taking an overdose of a poisonous seed, which is cardiotoxic. Now, when it comes to gender distribution, usually when you talk about borderline personality disorder, we talk about women having a borderline personality disorder. And as such, the diagnosis is most commonly made in women. Men are underdiagnosed, and often they are seen in drug and alcohol services and prison settings. But when you do a community prevalence study, there's no gender inequality, and the gender distribution is equal. Both men and women have equal prevalence of borderline personality disorder. Now, we discussed earlier on saying that according to DSM-5 definition, BPD usually emerges during adolescence, which is true. However, BPD can present across lifespan. Late manifestation of BPD has been reported. In fact, at the service that I work, a third of our patients tend to have late manifestation. Usually they develop symptoms of borderline personality disorder in their late 50s and 60s. I'm sure you're all very familiar with the clinical features, but just to emphasize, instability is the hallmark of borderline personality disorder. Instability with respect to emotions, instability with respect to relationships, instability with respect to a sense of self-identity. And impulsivity is another symptom. A sense of emptiness, a shallow emptiness, is a very painful symptom that many people with borderline personality disorder can have. Of course, non-suicidal self-injury and suicidal behaviors are signature symptoms of borderline personality disorder. Suicidal behaviors are a diagnostic criteria only for borderline personality disorder and depression in classificatory systems, as you know. Anger discontrol is another symptom, and we can also have micropsychotic episodes or dissociative episodes as part of the symptom profile. Please note that anger discontrol is a symptom, is a diagnostic criteria for borderline personality disorder. Therefore, we can't really get upset with people with borderline personality disorder if they get angry, because they're getting angry because that's a symptom. Now, some experience a chronic sense of emptiness, which some of the researchers have called it as identitylessness. You can imagine the amount of psychological pain these patients can experience when they have a sense that they don't have any identity. So these are the 9 criteria listed in DSM-5 for a diagnosis of BPD, and you need only 5 out of 9 to make a diagnosis. And these are not weighted criteria. So therefore, if you do your permutations and combinations, you can nearly have about 256 subtypes of borderline personality disorder. BPD is often considered as the king of comorbid kingdom. So coexisting disorders are very common. It is a norm rather than exception. Only 5% of patients with BPD present in their pure form, and depression being the commonest, substance use in 2/3 of patients. In fact, 90% of people with BPD can have other co-occurring personality disorders. That's why the categorical approach is considered useless. That's why we are moving towards a single unitary diagnosis of personality disorder. You can also have all the other psychiatric disorders as comorbid disorders. Now, because of this, often what tends to happen is people tend to treat the co-occurring disorders. That is, people tend to, if someone has a depression and borderline personality disorder, tendency is to treat depression because that is a disorder for which there are biological treatments we are all very, very well versed with. So we treat depression without treating borderline personality disorder. We know, and it has been established quite well in several randomized controlled trials, that if there is depression with borderline personality disorder, unless you treat borderline personality disorder, If you treat only depression, the depression doesn't respond to biological treatments. So borderline personality disorder offers treatment resistance. However, if you treat only borderline personality disorder without treating the co-occurring depression, both borderline personality disorder and depression can go into remission without biological treatments. So showing that borderline personality disorder is the underlying causative disorder. So that rule of thumb applies to most of the comorbid disorders. So if you're treating comorbid disorders, beware that you must also treat borderline personality disorder. What's the cause of borderline personality disorder? Of course, the last word has not been said. And up to 85% of people report history of trauma, childhood trauma most commonly, sexual abuse, invalidation, bullying, etc. However, up to 10% of people with BPD report no childhood traumatic experiences or attachment difficulties. So you can't really find a psychological or psychosocial etiological factor as a causative agent in about 10% of the people. Attachment problems are, of course, quite common in borderline personality disorder. So what we now know is that trauma is very common, and it is a risk factor, but it is not essential for development of borderline personality disorder. There are studies to show that if you follow up children who have suffered trauma, childhood trauma, even sexual abuse, guess what happens to majority of them when they grow up into adulthood? Most of them do not have psychiatric problems. 80% of them have a normal development. 20% of them develop a range of psychiatric disorders. BPD is only one of them. And BPD people can develop BPD even without history of trauma. So therefore, trauma is not essential for development of BPD or to diagnose BPD. This is a very common misunderstanding. There are several biological abnormalities in BPD. We now know that there is 50% contribution of genetics to the development of borderline personality disorder. What is probably inherited is the abnormal biological system, abnormal emotional system. We know that amygdala, as you're aware, amygdala is the seat of generation of emotions and control of emotions, and that is abnormal, and it is hyperactive in BPD. And the prefrontal cortex, which usually regulates and modulates the amygdala, is quite poor in its control mechanisms over the amygdala. We also know that there is abnormality of the anterior insula part of the brain, which renders people with borderline personality disorder incapable of cooperating. So if people with borderline personality disorder are not cooperative while you're providing care, it's because there is a biological abnormality. So what we know is that amygdala is hyperactive. The prefrontal cortex, which is supposed to dampen and control the emotions, that is also abnormal. That is, the controls from prefrontal cortex to amygdala is very poor. So therefore, you have a situation where the emotions are firing and the inhibitory controls are very limited. Now, if we compare the emotional system of someone with a BPD to a car, then the person with borderline personality disorder is driving a car with a hypersensitive accelerator and poor brakes. The accelerator being the emotions, the brakes being the prefrontal cortex. So no wonder these people can go through red lights and can have erratic driving in a metaphorical sense. Now, you can only imagine how a clinician who is going to help a person with borderline personality disorder in treatment. Now, the demand on the clinician is to be a driving instructor, sitting in that car, which has got poor brakes and very, very sensitive accelerators, and teach the person with borderline personality disorder how to drive that car. Because he's not going to get a new car Well, that's the life, isn't it? So the idea is that the clinician would be an empathic instructor and share the risk and teach the person how to drive that car. What the evidence shows is that over a period of time, through psychological treatments, people with borderline personality disorder can learn and will learn to drive that car in such a way that it is safe. Now, the Australian NHMRC clinical practice guidelines makes the statement that having borderline personality disorder is not the person's own fault. It is a disorder of the brain and the mind. Saying that it is a legitimate psychiatric disorder like schizophrenia, bipolar disorders, it is. And also that these patients can be difficult to treat, but it is the illness that produces the behavior, not the person. Even if you forget all of the rest of the things I've said so far, and I'm going to be saying after this, if you just remember this slide, that's going to make a huge difference to your practice. The reason why we all struggle to work with people with borderline personality disorder, at least according to me, is that we don't struggle so much to work with people with schizophrenia, bipolar disorders, and other psychiatric disorders because we understand those disorders as legitimate psychiatric disorders. We think that the people's biochemical changes are there, and it is not the person's fault. However, when it comes to BPD, people with personality disorder, we tend to blame the person. We think that they have the control to behave properly, but they're deliberately choosing not to. So therefore, we get upset and angry with them, or we dislike them. But if you understand that it is the people's behaviors are a product of their illness, then it is very likely that our ability to work with these patients will improve dramatically. Now, in the Australian setting, we find that almost everybody who dies by suicide with a diagnosis of borderline personality disorder present to mental health services. 99% of them go through mental services in Australia in the preceding 1 year. And a quarter of them in the preceding go to the emergency department 6 weeks before they die by suicide, and 88% of them again go to public mental health in the preceding 6 weeks before they die. And most of the suicide tends to be between the age of 18 to 64. Okay, let's talk a little bit about the treatment of BPD. There are no medicines that are patented or indicated for treatment of borderline personality disorder. This is unfortunate because there's hardly any research has happened to find an original molecule to treat borderline personality disorder. In the last 70 years, there's plenty of research that has happened where people have tried to use the current psychotropic drugs. I'm talking about antidepressants, antipsychotics, and mood stabilizers and anti-anxiety medicines to see whether they would work for borderline personality disorder. Of course, they don't. However, we know that the psychological treatments work and they are the treatment of choice. I'm not expecting you to read all the slides, but this is a list of all the evidence-based specialist psychological treatments for borderline personality disorder. They're all evidence-based. They're all equally effective. Sorry, I think the slides are jumping for some reason. Now, acceptance and commitment therapy is one of the treatments that we have developed a model in Victoria, and our treatment is called Wise Choices. These are some of the generalist treatments: structured clinical management, general psychiatric management, good clinical care, even supportive psychotherapy, which has been specifically developed for borderline personality disorder. They're all equally effective, and they are as effective as specialist treatments. What we are now finding is that between all of these treatments, including dialectical behavior therapy, mentalization-based treatment, etc., there are more commonalities than differences between all of these treatments. Very similar to antidepressants. As we know, most of the antidepressants work equally well. So that's the same story with treatment of treatment of personality disorders with psychological treatments. So there's some research which has happened to look at the commonalities in all of the specialist and generalist treatments, and they all seem to work very well. And according to the Australian guidelines, again, what it says is that the people with borderline personality disorder should be provided with structured psychological treatments that are specifically designed for BPD, conducted by one or more adequately trained and supervised health professionals. So integrated common factors and stepped care treatments that are adapted to the local mental systems are the way to go, whether it is Australian or Sri Lankan. Borderline personality disorder is a good prognostic disorder. There are several long-term studies, outcome studies, and there's one study which has gone on for more than 25 years. So the summary of all the studies is that 10% of the patients tend to respond in 6 months' time, 6 months of psychological work. Quarter of them in 1 year, half of them in 2 years, and up to 85% of them can go into remission in 10 years. And 60% of them not just go into remission, they actually recover. Recovery means having meaningful relationships and holding permanent, long-term, holding full-time jobs. Look at the relapse rates. It's extremely small. So once people improve, they tend to maintain the recovery, and very few people relapse. Compare this with depression. As you're aware, in depression, 50% of them, half of them, tend to relapse. So relapse rates are quite low in borderline personality disorder. This is again another way of demonstrating remission and recovery. When you do specialist treatments, those outcome data is for any treatment. This is for specialist treatments. For specialist treatments such as mentalization-based treatments or dialectical behavior therapy or general psychiatric management, which is again a specialist treatment, the remission rates are in 1 to 2 years' time, about 2/3 of them go into remission. Now, a few slides about medicines. As I told you, there is very limited data to support medications. Now, quetiapine, there are a couple of randomized controlled trials to support the use of it in crisis management. As you know, people with borderline personality disorder go from one crisis to another crisis to another crisis, barely recovering from the previous ones. A quetiapine in the dose of 25 to 150 milligrams, even average dose is about 50 milligrams a day, prescribed for 1 to 2 weeks, can be quite helpful for crisis management. Again, we don't know whether it is because of the side effects of, and also anti-anxiety kind of effects rather than any core biological changes of BPD. Topiramate and lamotrigine have been reported to be effective against anger, aggression, and mood instability. I use lamotrigine a lot. Even at the dose of 50 milligrams, lamotrigine can be quite helpful. As you're aware, lamotrigine is weight neutral. Again, a big plus in BPD. One problem with lamotrigine is that it can cause, in a small percentage of patients, it can cause Stevens-Johnson syndrome, the skin reaction, dreaded skin reaction that you need to be aware of and keep a lookout for. If you increase the dosage very, very slowly, that tends to be very, the prevalence of Stevens-Johnson syndrome can be reduced. Also now there are some genetic screening you can do to see if people are vulnerable for Stevens-Johnson syndrome with lamotrigine. Aripiprazole, again, there's a little bit of data, 2.5 to 5 milligrams a day for anger, aggression, depression, and some psychotic symptoms in BPD. Fluvoxamine for controlling rapid motions. Again, data for all of this is very limited. I would suggest that if you're using medications, use it for short periods of time. If it is for crisis, not more than 1 to 2 weeks. If it is for symptomatic control, try for 3 to 6 months, but don't prescribe them for years and years and years. Fluoxetine, a lot of data. Again, not conclusive. SSRIs were very popular in the past. That is gone now. Nowadays, we use the third generation anti-epileptics such as lamotrigine and topiramate or antipsychotics. Olanzapine can be helpful even in small doses, 2.5 to 5 milligrams. But again, the weight gain is a significant problem, as you're aware. So there is some data for omega-3 fatty acids. There is omega-3 fatty acid which has got the 1200 EPA and 800 DHA and given in 4 capsules per day. That seems to be somewhat helpful. The preparation that is available in Australia is called the Ultra Clean, which is over the counter. Again, because of the safety profile of omega-3 fatty acid, that becomes an attractive option. Now, coming back to psychological treatments. Often treatment of BPD with psychological treatments is considered to be a rocket science, which it is not. In fact, we have done injustice to people with BPD by selling the treatment of BPD as being highly specialized skill, which I for one don't believe that it is. So I believe that most clinicians, any general psychiatrists who have some background in psychological work, which most psychiatrists are, can work with people with borderline personality disorder using treatment principles. John Gunderson, in fact, makes a statement that most clinicians can effectively treat most patients with borderline personality disorder. Jo Bateson is one of my mentors. She makes a statement that effective psychological treatment of BPD can be provided by clinicians who lack specific training in psychotherapists. So what are the essential treatment principles? First of all, make a clear diagnosis of borderline personality disorder where it is present and delineate and document all the co-occurring psychiatric disorders and also medical disorders where polycystic ovarian syndrome is present in about a quarter of the patients in BPD. Chronic pain conditions are present in a third of people with borderline personality disorder. So delineate and document all the comorbid diagnoses with psychiatric comorbid diagnosis as well as medical. Try and make a comprehensive assessment of risks. Risk for non-suicidal self-injury and risk for suicide. Have an understanding of why people with BPD self-injure. Ask them, most of them will tell you. Develop a collaborative crisis management plan. Asking patients and the family, what should we do if you next time self-injure? What should you do if you feel like attempting suicide next time, etc. What are the conditions where you may be hospitalized? Now, also do psychoeducation to patient and family, discuss the treatment and the diagnosis, and setting up a contract of care, a written contract of care. It can be on a letterhead. It can be about 10 lines, handwritten. Avoid hospitalization as much as possible because what are you going to do in the hospital? You can't really do an urgent psychotherapy and you can't really give any medications to fix the problem. So, but use hospitalization if it is if the situation is life-threatening. What you don't want to be doing is hospitalize patients and change in chalk medicines every single time. That is very unhelpful. Or long hospitalizations can be problematic because patients often get into big trouble with the hospital staff, and they would find it hard to get discharged. Use medications very judiciously, if at all. So collaborative approach is the most important one, and you need to find reasons to validate people with borderline personality disorder. So validation is an important skill, but it can be quite challenging. I'll see whether I can show you a video at the end as to how it can be challenging. And we need to keep working on skills to change for people with borderline personality disorder and focus on change intervention skills such as skills to regulate their emotions, manage the crisis, manage the interpersonal dynamics. Keep an eye on the emotions. Both clinicians and patients can have strong emotional reactions. So keep an eye on the patient's emotions, help them to regulate. And if we as clinicians develop our own emotional reactions, the countertransference, which is very common in borderline personality disorder. So we need to become aware and metabolize and manage our own emotions, not react to patients with their emotions. Often people with borderline personality disorder can't connect their actions with their feelings and thoughts. Common example is that a person with BPD might have had a relationship breakdown, and following that, they might attempt suicide or attempt to harm themselves. But they may not connect their suicide attempt with the feelings of fear of abandonment that they may have developed following a relationship breakdown. So it is important for us to help them connect those things. Although it might be very obvious for you, but it may not be that obvious for the patients. Fostering self-responsibility is very important. Treat them like adults, don't fragilize them. Pay attention to the therapeutic relationship. Having a positive relationship with patients is extremely important, the therapeutic relationship. Also, a word of caution that the therapeutic relationship needs to have clear structures and boundaries. If not, boundary violations can occur. Seek supervision, speak to colleagues. Even if you can't access formal supervision, talking to colleagues about your challenges in working with borderline personality disorder patients can be very helpful. What we know is that clinicians who are trained, who are active, who are willing, who hold hope, and who are enthusiastic seem to do well with people with BPD. We need to encourage patients to get a life, which is work and relationships, not just remain as patients for years and years and years. So the take-home message is any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to persons with borderline personality disorder and, as such, persons with any personality disorder. This is a statement made by Mary Zanelli, one of the most eminent researchers in personality disorder field. And the other take-home message is that as long as you don't judge, as long as you try to validate the valid in the patients, and as long as you can tolerate emotions, your own emotions and their emotions in your therapeutic work, and teach patients skills to improve their quality of life, you can contribute to the recovery journey. So give it a go. So that's the end of my presentation. I want to now show you a video. I hope it works. This is a video which demonstrates the challenges in doing validation with people with borderline personality disorder. I'll try and see whether I can share it. Let me see. Please let me know if you can't hear the audio.
It's just, there's all this pressure, and sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Come on. If you would just
Don't.
Okay, so what that video shows is that although this woman has a nail in the head, we all know that that's the problem. Most probably, she also knows that that's a problem. That's a reason for the headache. That's a reason for tearing all her sweaters, etc. But what she's asking is for validation. What she's asking is for the person to actually listen and understand her distress. What this guy is trying to do is to fix the problem, which is to pull out the nail. So that is a common problem when it comes to working with people with borderline personality disorder, because we as clinicians can clearly see the problem and see what they need to be doing in order to address the problems. But they are not in a position to see it and solve the problems because they're actually seeking for validation first. Once you validate them adequately, then you're able to point out gently and help them to see for themselves that they need to remove the nail. That's what is going to solve the problem eventually. Okay, I'll stop here. Happy to take any questions and comments. Thanks, Gehan. Thanks for listening.
Yeah, thank you very much, Professor Rao. Hope you can hear me.
Yep, very well.
Yeah. Now, I think there are maybe quite a lot of questions from the audience. Can I start with a very simple question? Now, in your experience, now we are always talking about, when talking about borderline personality disorder, we are talking about females or women. What's your experience about borderline personality disorder in men in Australia?
Look, about 10% of our patients now tend to be men. In the outpatient clinic, when we do the diagnostic assessment, 30% of them are men. But very few people actually come to treatment. The reason we think that is because I don't think our treatments are suitable for men. And also all the research that we have to date. So if you look at the research for personality disorders we have, 99% of it is for women with borderline personality disorder. So there is only now in the last few years we have started researching men. It'll probably take a few more years before we have a comprehensive understanding of treatment of men with personality disorders. But often, anecdotal experience is that often men with borderline personality disorder tend to have anger discontrol, which often is misdiagnosed as antisocial personality disorder. And people are generally find it hard to work with men with borderline personality disorder. And substance use, again, is a common comorbidity.
Thank you. And
when it comes to suicide rate in Australia, what we demonstrate is that it's 50-50. Completed suicide is 50-50 for men and women.
And in Australia, do you find men with borderline personality disorder presenting with self-cutting and overdoses like in the women? Not so frequent, isn't it?
Cutting is much more severe. Substance use is more common, and they generally have more problems with the police. Overdose tends to be little less, relatively.
So you see more aggression in men than in women with borderline personality disorder.
It's the same, but because of the gender, when men get angry and aggressive, it is perceived as more dangerous than when women get angry and aggressive.
Thank you. Any other questions you may ask from Professor Sathya Rao?
Hello. I'm Dr. Amile Suru, consultant psychiatrist. Thank you so much, Professor Sathya Rao. This is very enlightening, the very useful lecture. And I have a question. So most of the time, the family members or caregivers are struggling to take care of patients with borderline personality disorder. When we approach patients, when we help them, do we have any specific package or specific way to treat, way to help out the caregivers?
Yep, I think it's a very important question. Thank you for asking. Now, we have see, I work at Spectrum. We have 2 family members, carers, who actually work as carer consultants. They run family education programs, and they also help other family members who have loved ones with borderline personality disorder. So it's important because, see, we see patients for 1 hour a week maximum, right?
Yeah.
In some settings, people might be seen only once in 2 or 3 months. Rest of the time, it's the family members who are managing people with borderline personality disorder, and their behavior, their action, their suicidal behaviors. So it's extremely important to educate. Number one is important to educate families. Number 2, also teach families how to respond if with borderline personality disorder are expressing suicidal thoughts, or if they do cutting, how to respond, or if they get angry, how to respond. So the kind of techniques that we use, we need to be able to teach some of them to family members so that they can also manage their loved ones at home. So there are a lot of packages available. If you look at the Spectrum website, so there are certainly packages available, and maybe I could send some of the material to you via email.
Yeah. Yeah, thank you, sir.
Thank you.
That's really helpful. Yeah. And the other thing is the family members take it personally. For example, if we get a daughter with a diagnosis of borderline personality disorder, when she interacts with the mother, all her comments and all her behaviors is very personal to mother. In my personal experience, it's most of the time this parents, mother, always kind of struggling to kind of how to respond to their children or other. Yeah.
See, again, if you remember, for a long time, we used to use this phrase "schizophrenogenic mother." Some of the older generation psychiatrists might remember this. So in the past, we in psychiatry have blamed mothers and fathers for development of psychiatric disorders. Fortunately for schizophrenia, we no longer do that. For borderline personality disorder, still there is a feeling that family members have actually caused the disorder. So we need to move away from that. We need to see BPD as any other psychiatric disorder. And family members are trying to do the very best, have done the very best they can.
Thank you very much.
Hello, sir.
Thank you.
This is one registrar. So this is Dr. Herath, one registrar.
Go on, Jayant.
Yeah. One thing that you told that personality disorders can be diagnosed even in the late ages. And is it? Are you referring to organic personality disorder or
No.
Or this person that we are talking about here? Can we be diagnosed late in the life, sir?
Look in the olden days. When I say olden days, I'm talking about 20-30 years ago. We used to think that personality disorders almost always started during early adolescence, early adulthood, and it goes on and on and on for the rest of their lives. So that was what we thought personality disorders did. It's no longer true. So in fact, the very definition of personality disorder, the DSM-5 definition, has been challenged, because personality disorders can start for the first time in late adulthood, in midlife. See, a third of the patients at Spectrum, maybe where I work, they are in their 50s and 60s. So they develop the disorder for the first time in 50s and 60s. The common story is this: they've had some childhood trauma, and they've had some symptoms during adolescence, maybe 1 or 2 episodes of self-injury or some minor eating disorders. then they have either met a person with whom they have established a long-term romantic relationship, they got married perhaps, and or they have held a job which has been meaningful for them. So either an occupation or a romantic relationship has provided the containment for them. So they've not developed any borderline personality disorder. Now, in their 50s and 60s, either they lose the job or the romantic relationship has gone sour, and there's been a relationship breakdown or marital breakup. Then they present for the first time with the full syndromal expression of borderline personality disorder. So until 50 years of age, they have not been detected as a case because they have not been symptomatic, although they have had the vulnerability factors. So they can develop BPD for the first time in the 50s and 60s. Even after 65 years of age, we have seen people developing for the BPD for the first time. In recognition of this, ICD-11 in the earlier drafts actually came up with a qualifier for late onset personality disorder. So personality disorders can clearly start later at any age.
Thank you, sir.
Hello, I am Professor Kuruparachi from Sri Lanka. I just want to ask a question. We see these adolescents with borderline personality disorder picture as well as affective instability, and subsequently when you follow up, they end up with having bipolar affective disorder. Do you have that experience in Australia also sometimes?
Look, about 5% of patients with BPD can have co-occurring bipolar disorders, 5%. But what we most commonly see is people with borderline personality disorder having maybe an episode of mild hypomania and depression, bipolar type 2. That can happen. Again, of course, for those people, we would prescribe mood stabilizers. In fact, in my practice, Professor, we would prescribe lamotrigine or topiramate to control both bipolar disorder, and we know that that can also be somewhat helpful in borderline personality disorder. Now, what we tend to avoid is sodium valproate and lithium. We tend not to prescribe those two medicines. Lithium, because the risk of overdose and death is very high, even if it is a self-injury, not suicide attempt. With lithium, as you know, it can be dangerous. Sodium valproate, again, because predominantly our patient population is women, it can cause more obesity, alopecia, and teratogenicity. And worst of all, we know that quarter of patients with BPD can also have polycystic ovarian syndrome. And as you know, sodium valproate tends to precipitate polycystic ovaries. So we tend not to do that.
All right, thank you very much for your clarification. Is there any comorbidity, not the comorbidity? Is it a spectrum, borderline and sometimes bipolar disorder?
We don't conceptualize it as a spectrum because if you talk about the ultra rapid cycling bipolar disorder, one can see how that can look similar to emotion instability of BPD, right? However, in ultra rapid cycling bipolar disorder, we see emotional instability, but we don't see instability in self-identity, interpersonal relationship. We don't see the self-injury and suicidal behaviors. We don't see impulsivity. We don't see the fear of abandonment, emotional dynamics. We don't see the other symptoms of borderline personality disorder. So that's probably one way to distinguish between the two. We don't think BPD as a bipolar spectrum disorder. This is probably a different class of disorder from mood disorders.
I just asked that question because there were some articles related to bipolar and borderline published in Religion, Psychiatry and other journals. So
correct.
I just want to clarify that. Yeah.
Look, there is one group of psychiatrists believe that bipolar disorder and borderline personality disorder are related. It is a spectrum. In fact, very famously, you would know Akiskal. Akiskal said that BPD is nothing but a type of mood disorder, which has been shown to be clearly untrue.
All right. Thank you very much for the clarification. It's a very nice lecture. It's a good lecture. Thank you very much.
Thanks, Professor.
Thank you.
Professor Rao, it's Aruni. Thank you for the wonderful lecture. Like you said, sometimes we, when we do the therapy, find it quite exhaustive. So how important is that we as a therapist receive some degree of supervision or at least peer review when you are treating patients with borderline personality disorder?
Yeah. See, Aruni, as you know, for all psychiatric disorders, it will be ideal if we can have some peer review and peer consultations, because we are treating with disorders of the mind, and our own minds can get impacted. However, when it comes to borderline personality disorder, supervision is not a luxury. It is not an add-on. It is seen as an essential component of treatment of borderline personality disorder. The reason is this: if we are working with people with borderline personality disorder, we are going to experience emotional reactions. That is inevitable. That's a given. Okay, our own emotions are going to be triggered. Now, when our emotions are going to be triggered, I don't think it is easy for us to become aware ourselves. So if we don't become aware of it ourselves, it can come in the way of treatment. I'll give you an example. So, in fact, and this is and the supervision is important for clinicians of whatever degree of experience and seniority they have, because that we are not immune to emotional reactions. Let me give you an example. This is just about 2-3 years ago. I've been working with someone with borderline personality disorder, and she was doing quite well because I treated her for about 2 or 3 years. At some stage, she started talking about suicidal thoughts. See, I'd worked with her with suicidal thoughts and suicidal behaviors in the past, but this particular time, for some reason, I became very anxious. So I saw that she was becoming more and more unwell with respect to suicide risk. And at one stage, she even brought a rope to the hospital saying that she's going to kill herself. For some reason, I got very anxious that I might lose her. I took second opinion, I took third opinion, I sought supervision. Despite that, I couldn't really come up with answers. One day, I sort of penny dropped for me, and I actually asked her, "Why do you think this is happening?" You know what she told me? She said that she made this statement that she said, "Look, I saw you becoming anxious. Because you became anxious, I felt more and more suicidal. Because I thought there's no hope. If you yourself is getting anxious, there's no hope for me." So my anxiety, which is a countertransference, actually triggered and worsened a suicide risk. I've been working with in this field for 25 years. I could not make out my own emotional reaction. So unless someone, a patient in this case, pointed out to me. So it's important that we become aware of our own emotions, and that's why we need supervision.
Right. Thank you, sir.
Professor Rao, this is Gihan here again. Now, as we now in Sri Lanka, unlike in Australia, we don't have a lot of clinical psychologists. And in the UK, when we worked in the UK, they were quite strict on the resource persons for dialectical behavior therapy, that you have to strictly have 2 work therapists and 1 clinical psychologist in the program, and the program should run for at least 1 year and all that. But I don't know about Australia, the DBT service there. Now in Sri Lanka, as we don't have trained professionals as work therapists and clinical psychologists, we have a few. So is it possible that I don't know about your experience, to train other staff like counselors or occupational therapists in the 4 modules like the interpersonal effectiveness, emotional regulation, distress tolerance, and mindfulness, and incorporate them into a treatment program and run a program with limited resources or not fully trained professionals. What do you think about the effectiveness of such a DBT program for a country like Sri Lanka?
Gian, that's a brilliant question. Look, if I've been doing some training for India too. I come from India, very similar conditions as Sri Lanka, as you know. In fact, we are in some of the situations much worse in India. Now, we don't need to mimic the Western model. Number one. Number two, the research shows that DBT is not superior to any other psychological treatment for BPD. It is not superior. Only thing is, it has had that many research trials, because Marshall and did a lot of research on it. Just because it is research more doesn't mean that it is more evidence-based. Now, if you remember, I showed you some slides saying that all psychological treatments for BPD is equally effective. And there are more commonalities than differences. And we can distill the essential treatment principles out of all of them. And if we use them, and there is research to show that that is as effective as DBT. Number one. Now, generally, if clinicians are trained, it seems to work well. Now, there is one very interesting study that has been done in Australia. In Australia, they showed that they did a research trial showing that they took 3 groups. One is the regular case management, regular public hospital case management. Second group, they administered a specialist BPD specific psychological treatment, highly specialized treatment. For the third group, it was just befriending. Befriending is someone with a common sense, not having any mental health training, someone with a common sense, catching up with the patient on a weekly basis and spending the same amount of time a case manager spent, same amount of time a psychologist spent, providing specialist treatments. Guess what? At the end, what happened? All of them were equally effective. Even befriending was as effective as specialist psychological treatment. In fact, the dictum and the teaching in BPD is that as long as you're doing something, some work with people with borderline personality disorder, it seems to work. It seems to help. Of course, now we're talking about very basic principles. Now, someone needs to be not put them down, not criticize them. Try and validate the valid. Try and point to them their emotions. Try and help them understand their own lives. We're talking about really basic psychological skills. One of the slides I also showed that even supportive psychotherapy, which is informed by BPD, can be helpful. So if in Sri Lanka, you're able to employ other additional mental support staff and train them up, there's no reason why that can't help.
Thank you. Thank you very much.
In fact, I would actively support that.
Yes. Any other questions to Professor Rao?
Hello, I have a question, Professor Rao. I'm Sathya, and my question is regarding the etiology. Actually, I'm mainly asking about the perpetuation rather than the onset or development of the borderline personality disorder. And in Sri Lanka also, we have borderline personality disorder, but we don't see many cases. But what I thought, my question is whether there is an element of iatrogenicity in the causation, at least in the perpetuation of the disorder in countries, developed countries, because we don't see severe or many cases in Sri Lanka because we don't have services and we don't sort of in a way reinforce the diagnosis of the disorder, and we take the patients to take the responsibility. So I'm wondering whether there is an element of iatrogenicity, at least in developed countries, when it comes to the borderline personality disorder.
That's a very interesting question. I tend to partly agree with you. I think there is iatrogenicity, in at least in the developed countries, with respect to expression of some of the symptoms. Specifically, suicidal behavior, self-harm behaviors with which they keep going to emergency department, keep seeking hospital admissions. That tends to be, I can see how you might want to interpret that as some of the culturally determined factor, which is true. And if in developing countries where we don't have that many facilities, that doesn't get reinforced.
Yeah.
That part of it, I agree. However, my own belief is that a borderline personality disorder as a core psychiatric disorder is present across the globe, across cultures. The expression might be slightly different. Expression may be culturally determined. So if you think of people, both men and women, who are more emotionally sensitive, who are more impulsivity, who suffer significant psychological pain, those things, and have difficulty in interpersonal relationships, who fear abandonment in relationships, those things are there across the world, in all cultures. So the expression might vary, but the core disorder, I believe, probably is present everywhere. Now, I'm aware of what's happening in India and also in China. See, even in the last 25 years I've been working in the field, initially we never had any reports of BPD from any India and China, very little. As a student who I got trained in Bangalore, and where BPD, I had seen only one patient with BPD throughout my 7 years of training as a registrar and a senior registrar. However, now I know, when I look back, a lot of the women who used to take overdoses and present to hospitals, general hospitals, who never used to go to psychiatry wards, and they used to be discharged from the emergency department after we did the medical treatments, probably had borderline personality disorder. Thank you.
Thank you.
Any more questions to Professor Rao?
Hello, sir. Hello, sir.
Yep.
Yes, I'm Rubini, registrar psychiatry. Just for my interest, knowing the burden of the borderline personality disorder worldwide and from the etiology of this attachment problems and trauma, is there any concern regarding the prevention which has taken up in Australia, sir? Though we don't have any, is there any concerns about preventing and educating the parents or the population?
Yeah, look, that prevention is a very interesting idea. What we probably understand a little bit more, we are not there in I don't think we understand prevention much. Probably what we understand more is early intervention. There's been a lot of work in Australia for early intervention. So we make a diagnosis of borderline personality disorder from the age of 12, 1-2, post-puberty. So if we can catch the disorder early, we treat the disorder as soon as we make a diagnosis, so that we can prevent the disorder from becoming more severe, more entrenched. That's number one. If you're looking about prevention, probably what we need to be looking at is we need to start from infant mental health. We need to be doing a lot of education, population level education about the need for positive attachment, forming near positive attachments, and the infant mother and the parent relationships in the first 5 years of life, as well as if children are exposed to trauma, how to do early intervention for those trauma experiences. Those are probably some of the things we can do in terms of prevention, but we are not there yet.
Okay, sir. Thank you so much.
Okay, Professor Rao, shall we then wind up for the day?
So thank you. So
Yes, just give
all the questions.
Give me a minute. Yeah, so let me again thank you immensely for taking your time off from your busy work schedule and sacrificing your Sunday evening for the sake of the Sri Lanka College of Psychiatrists and our members. Thank you very much. It was a very stimulating and enlightening lecture. And in spite of the curfew and power cuts in Sri Lanka, and we don't have lights now, we had more than almost 90 participants attending your lecture today. So it's very encouraging, and that shows the enthusiasm of our members to listen to your lecture. Thank you very much. And especially, I must thank you for enlightening us on the etiology, the epidemiology, and also the treatment of borderline personality disorder. And even more than that, especially for highlighting the change of attitude that we need to show regarding borderline personality disorder, and not look down upon them and not blame the symptoms on the patient, but the disorder. And I really like the way that you expressed or explained about the accelerating car without applying of brakes. So hope we could copy your slides for the medical students, because that will be really interesting to make them aware of how and why they behave in such a manner in borderline personality disorder. And as I told you earlier, in Sri Lanka, we are increasingly detecting borderline personality disorder because we are vigilant about it now, although we don't have much services available. And as we don't have a structured treatment program as such in the UK or Australia, but your presentation and your attitude and views regarding borderline personality disorder will really help us to formulate treatment programs with the limited resources that we have. And it really caught my eye, the phrase or the slide that you did or mentioned, reasonable treatment in a reasonable manner by reasonable clinicians. So that is what we have. So we are having enthusiastic clinicians who are really interested in treating borderline personality disorder. So the enlightenment and the stimulation that you gave us today will really help all of us as clinicians to formulate treatment programs for our unfortunate patients in Sri Lanka. And it's really, I think, eye-opening because we, as you quite correctly pointed out, don't wait till the ideal conditions or for the ideal resource persons. So do what you can with what you have is, I think, what we need today for countries like Sri Lanka. Thank you very much, Professor Sathya Rao, for your valuable time and for your very stimulating and interesting lecture. Thanks a lot.
Thanks, Gyan. Happy to send my slides as well as the resources that I mentioned.
And let me again thank Dr. Aruni Hapangama for coordinating this program, the lecture, and Dr. Chamara Vijay Singh and Dr. Sumudu Godavita for all the assistance given in conducting and facilitating this. Thank you very much.
Thank you. Good night.